Hi, everybody. Thank you so much for joining. We'll just give it a minute until we let everybody in from the waiting room. Thanks everybody for joining us today. My name is Libby Sagara. I'm with Blue Path Health, and we are the eConsult work group. I see a lot of veterans to our group, those who joined us on our past monthly calls. We've been around for about 6 years now. If you're new to our group, thank you so much for joining us today for such an important topic on eConsult and tools in response to behavioral and mental health needs. I know we still have a few people coming in from the waiting room, so I'll run through our agenda slowly here. As we all know, May is Mental Health Awareness Month, such an important topic for many reasons. And I'm so glad we have a group of presenters and panelists that present very diverse perspectives. We have Angela Vasquez, Director of Policy from the Children's Partnership, presenting their recent publication on hope, healing, and health. I was so pleased to see this come out yesterday. It's timely, important for so many reasons. I'm so glad Angela was able to join us. We're pleased to have Autumn Boylan, the Deputy Director of the Office of Strategic Partnerships from California DHCS. Autumn, we're so glad to have you bring in the state perspective. So excited to see such talk and emphasis on children and youth behavioral health and tools at the state level. So we're glad to have Autumn talk a little bit about what's happening up in the next year. We have Alicia Pimentel, a program manager from Anthem Blue Cross, speaking to the school-based health incentive program. I know schools are top of mind for all of us. We're going to be talking a lot about that and the timeliness of the importance of resources in schools. And last but not least, we have Petra Steinbuchel, who is a psychiatrist and also director of the UCSF Benioff Children's Hospital Child and Adolescent Psychiatry Program, which the acronym is CAP. Petra has been a long-time supporter of eConsult and telehealth and the importance of having that resources for providers and patients. So she'll talk a little bit about how this is being put into practice. So I'm glad to have very many different perspectives today. We encourage you all to use your chat, share questions and comments for our presenters. I know since we have such a great number of people on today, we'll have over 50 people. It's hard to have an active verbal discussion, but we will allow for some Q&A and allow for folks to take themselves off mute after our presenters speak today. In the meantime, thanks for keeping yourself on mute during our presenters' talks. They will keep it brief. They're just going to give us some 5-minute overviews of their programs, and then we'll get into some time for Q&A. Just quickly, in case you're new to the eConsult work group, we meet about once a month. We talk about eConsult policy, resources, support, use cases, education to be able to better enable providers to perform eConsult. We like to offer education and resources and publications that help payers and consumers to understand better what eConsult does and what it is. So hopefully that answers some of your questions today, or will answer some of your questions around eConsult in practice. And we encourage questions for us as a work group too, as we conduct our discussion today. So with that, I am going to just share what also came out as a publication this week, or in the past couple of weeks, around the importance of eConsult in response to our behavioral and mental health needs of our patients. We know that in-person behavioral and mental health is so important, especially in California, but we also know that having these in-person visits is quite a challenge, or being able to support the increased need for behavioral mental health services. So this was an interesting publication that came out of Health Affairs last week, noting that not only do we need these in-person services, but we need to look at new modalities, which we often talk about eConsult as a newer modality in providing telehealth not only for other clinical topics, but for behavioral mental health. So we'll hear a little bit about that today. And we'll make sure to share all these resources for you in the chat too. So without any further delay, I want to hand this over to Angela Vasquez, Director of Policy at the Children's Partnership. Angela, could you tell us a little bit about your publication that came out yesterday?
Sure. Thanks so much for having me. Happy to be with this group. I'm Angela. I'm the policy director over covering a portfolio that includes mental health, as well as child welfare and other system-involved youth issues. I am a social worker by training and have been in children's health and well-being public policy for the last 10 or so years. I am really excited and also sort of sobering reality for the need for this report, especially not just this week, but the last few weeks. We have really seen that our communities, especially our historically marginalized communities, Black and Latinx communities in particular, have been asked to hold an immeasurable and increasing level of grief and community trauma as it relates to, violence and oppression and systemic racism, really, across all of our systems, including health and mental health care. And so really it's been the work of the last couple of years at the Children's Partnership to put together what we have called the Hope, Healing, and Health Collective. It's a National Youth Policy Council in partnership with the National Black Women's Justice Institute. We pulled together 15 community-based organizations that work with high school-aged youth. Each of those 15 organizations nominated and supported a youth leader. Together with our youth leaders, we facilitated a series of listening sessions with their peers, again, all high school age youth, to try to uncover sort of what they viewed as essential components of a mental health care system that would truly meet their needs as marginalized youth. We really focused on the needs of Black girls, Latina girls, and LGBTQ youth and Native youth, because those were the subpopulations of young people that the data has shown both historically disparities in mental health outcomes, so greater levels of suicide attempts and self-harm, greater levels of depression, and also drastically less access to mental health care despite growing needs. And I think we also in our report have national data that really shows that just like the virus impacted the health outcomes of marginalized communities, the global pandemic and really the protests and renewed calls to action for racial justice after the murder of George Floyd has really landed hard on marginalized young people. Through these listening sessions, we established I think 13 policy recommendations, again, that are in the report that really seek to transform our mental health systems of care to better meet the needs of young people of color and marginalized youth. I can go sort of quickly over those policy recommendations. They fall under a few categories. The first is really that youth need meaningful access to quality care. What that really looks like includes lowering the cost of mental health care for youth and their families, including ensuring that youth have knowledge of and access to mental health benefits through insurance, whether that's through Medicaid or private commercial insurance, and also building up a workforce that is truly reflective of their communities and their experiences. What a theme that came up a lot in our listening sessions were that youth simply had a lot of mistrust about mental health providers broadly, but also in particular white providers that really gave that really sort of heightened their sense of mistrust for the mental health care system and engaging with it. They also uplifted many recommendations around family, race, and culture. One of the most salient for me is really that young people of color really want more access to healing and opportunities for healing outside of the mental health care system. So things like racial and cultural affinity practices, connections with elders, Native healing ceremonies. These were the things that were really meaningful and connected young people to a positive sense of self and their communities. And this is something I think that we heard over and over again, that civic engagement, activism was a mental health intervention in of itself. The idea that just because it's not therapy doesn't mean it's not therapeutic, I think was really, really important, an important theme that we heard from the young people. And then finally, we really honestly just heard a lot more desire from young people to be involved in creating policy and creating programs to ensure that that we are meeting all of their needs for mental health and well-being. One other piece before I wrap is that we did talk quite a bit about telehealth, and young people had mixed reactions and responses to telehealth. And so I think ultimately our recommendation was that we really need to engage youth and come up with modalities, a diverse set of modalities, even hybrid modalities, to ensure that we're meeting everyone's needs. And I'll stop there. Thank you.
Thank you so much, Angela. And I'm so glad you could join us today. We're thinking about youth and kids and their needs even more this week. This is not the first eye-opening tragedy that we've had, obviously, in our schools, but I'm sure this is top of mind for everyone. And thank you for sharing just what our youth are thinking and a resource that we should all take a look at to hear some new perspectives. And thank you for staying on. We'll hear from our other presenters and then have some time for discussion. And with that, I am going to introduce Autumn Boylan. Autumn, thank you so much for joining us today, bringing in the DHCS perspective and all the important work that is being done around the Children and Youth Behavioral Health Initiative. Go ahead, Autumn.
All right, thank you so much, Libby. My name is Autumn Boylan. As Libby said, I'm the Deputy Director for the Office of Strategic Partnerships at DHCS, which is a new program at DHCS focused on implementing the Children and Youth Behavioral Health Initiative. As Angela just said in her presentation, behavioral health challenges and outcomes for young people have been exacerbated over the last couple of years by not only the public health emergency, but the continued community, violence, police actions, and school violence, and just a host of other things that have really contributed to adding to the burden that young people have to bear. And the need for behavioral health services is really reaching kind of an urgent point. And so in California, we've recently made a fairly significant investment to try to address the unique challenges for children and youth in terms of meeting their emerging and existing behavioral health needs. The Children and Youth Behavioral Health Initiative is a multi-year, multi-department package of investments that really aims to reimagine the systems of support, regardless of payer source, for children and youth in order to access behavioral health services, and really specifically focuses on centering this work around the youth, children, youth, and their families, and the needs and voices of those young people. The efforts that we're engaging in through this initiative are focused on promoting social and emotional well-being, and preventing behavioral health challenges while at the same time providing equitable, appropriate, and timely services to meet the emerging and existing needs for children and youth. And this is for all children and youth in the state of California, ages 0 to 25. It's really important in this work, in light of some of the things that Angela just commented on in her presentation, that we stay grounded in focusing on equity in the work that we're doing. And we're really trying to be very centered and focused on having an equity lens and perspective in advancing the work, and making sure that as part of this, we're talking with young people from diverse communities, as well as community partners who are experienced in working with young people from our BIPOC communities, as well as LGBTQ plus and other marginalized groups within California. We also wanted to point it out that this is not a Medi-Cal initiative. I mentioned that already a moment ago, but the $4.7 billion investment of state general funds in California is really intended to improve access to behavioral health services across all delivery systems and all payers. So a child doesn't have to be enrolled in Medi-Cal or be Medi-Cal eligible in order to receive services under the umbrella of the Children and Youth Behavioral Health Initiative. In total, there are, as you see on the screen, 14 different work streams under the umbrella of the Children and Youth Behavioral Health Initiative, and 5 different state departments being led by our California Health and Human Services Agency. DHCS is responsible for a lion's share of this work, and I'm going to talk about just one of the work streams that we're focused on, which is the Behavioral Health Virtual Services Platform. But as you see on this slide, we're implementing multiple initiatives focused on bolstering school-based behavioral healthcare services, and we're going to have another panelist presenting on the SB-HIP initiative today, but there's also going to be a granting initiative to increase capacity and partnerships between schools and community-based organizations in order to enhance the availability of behavioral health services on school sites. We, through our CalHope initiative, have implemented contracts with all 58 county offices of education to focus on social and emotional learning environments in schools and to continue to foster environments of social and emotional wellness. We're expanding the infrastructure of the behavioral health delivery system through the Behavioral Health Continuum Infrastructure Project, which is dedicated funding to increase overall kind of facilities and capabilities in terms of the infrastructure to deliver behavioral health services and supports, as well as implementing new benefits in the Medi-Cal program by implementing dyadic care services and scaling evidence-based and community-defined practices across all delivery systems. Our partners at the healthcare department, or the Department of Healthcare Access and Information, is working on expanding and bolstering the behavioral health workforce in California, because we've heard through our stakeholder engagement efforts that workforce capacity is a significant challenge in all settings where behavioral health services are delivered. They're also establishing a new classification of workers, behavioral health coaches, to provide additional supports in school-based settings. We are partnering with the Department of Managed Healthcare to establish a statewide all-payer fee schedule for the delivery of mental health and substance use disorder services to students ages 0 to 25, so in all school-based settings up to the age of 25 across delivery systems. And commercial health plans and the Medi-Cal delivery system will be required to reimburse providers in accordance with the fee schedule once it goes live starting in January of 24. And then, of course, our partners at the Department of Public Health and Office of Surgeon General are focused on the public education change campaign, expanding the footprint of the ACEs Aware campaign, and implementing trauma-informed training for educators. That's just a quick overview of the 14 work streams you see in terms of the pieces that DHCS is responsible for the various launch dates. Some of these launched in this fiscal year, including SB-HIP and the Continuum Infrastructure Project. In 22-23, we'll be implementing the grant initiatives and implementing the new benefit in Medi-Cal. And then in 23-24, we'll be launching the platform and the provider network. Next slide. Really quickly, wanted to share a brief overview of the behavioral health virtual services platform, which would include a component of eConsult. As Angela also said in her presentation, we need to be thinking about the different modalities and ways that we are engaging with young people to engage with services. So one way that we're trying to do this is through establishing a virtual services platform that will include a variety of functions and capabilities and support delivery of appropriate and timely services. We want to be thoughtful about how this gets implemented so as not to supplant the existing delivery systems, because we do agree that in-person clinic-based services that are traditionally provided through the behavioral health delivery system are super important. But this is really meant to supplement those delivery systems and provide an option for young people who may be curious about services and want to reach out because they have some symptoms or some things that are going on, but they don't really know if they need help just yet. So it provides some supports to young people in those times, as well as to provide kind of a safety net for young people who are kind of between visits with their regular practitioners. We plan to launch in January of 24, as I said, and we'll be releasing a procurement later this year. On the next slide, we start to share just a quick overview of our vision and some of the guiding principles that's driving this work. So we really, at the end of the day, the most important thing that we're thinking about is that we build a platform that young people actually want to use. So to do this, we're engaging with young people in a variety of different forums through focus groups. We're going to their meetings. We're building a survey tool that we can help to get input, and talking with people in a variety of settings across the state, including working with several youth advisory boards from some of our behavioral health provider groups, as well as attending later next month a Friday Night Live event where there will be over 800 kids participating in a weekend conference. So we'll be going down. That's just one example, but looking for opportunities to engage young people through a variety of forums to make sure that we're building a platform that they actually want and that they will actually use. We also want to make sure that we're streamlining access and integrating across the behavioral health delivery system, that we're enabling clinicians, primary care and pediatricians primarily, to better support patients through eConsult feature, and want to make sure that we are focused on health equity by facilitating deep connections between children, youth, and families and care in their communities, while also making sure that we're thoughtful about privacy, anonymity, security, interoperability, and kind of all of the other system requirements. Next. This is just a quick overview of the capabilities that we're testing through our stakeholder engagement process. But we think that the platform would provide multiple different functions, including providing a place where young people could learn about their behavioral health symptoms and conditions, as well as strategies for wellness. And this would be done through interactive content, including videos, tools, games, and other resources. The platform will connect young people with peers, both through the platform and in their communities. We'll provide an opportunity for young people to engage with self-guided screening tools and to assess their behavioral health and what kind of support they might need. There will be a component of care information and navigation provided, so pointing people in the right direction to resources that exist at the local level, while also helping people to understand the rights and benefits that are available to them across the various delivery systems. There will be an opportunity for young people to actually receive care directly through the platform. That would be limited in scope. So we're thinking, maybe 3 to 5 or 3 to 6 counseling sessions with a behavioral health counselor or coach who can help to provide supports to somebody who may not rise to the need, to the level of need of needing clinical services. This would include AI-based digital assistants, accessing telemedicine-based behavioral health care directly with a provider, texting, phone, and chat services, as well as connecting to crisis supports that are being built out through California's crisis continuum of care. We'd also provide closed-loop referrals and warm handoffs to community-based payers, including providers that are through the traditional payers, the Medi-Cal managed care plans, commercial health plans, and counties, as well as tools and resources for young people to manage their behavioral health conditions over the long run. And then finally, which I think is something that's very much of interest to this group, is a provider to provider e-consult. We're still in pretty early stages in the discussion around the e-consult feature. We have formed a think tank to help us think through some of the policy and operational considerations for building out these capabilities. And we've invited several folks who are specifically experts related to e-consult, and I look forward to engaging with you further, all of you in this meeting, further about what that e-consult feature would look like and how that would integrate with the platform. On the next couple of pages, there are some additional details related to the virtual services platform, and I'm not going to go into detail, but they're provided here as backup. So it's a little bit more detail behind some of the things that I just talked about. And I think that might be all I included for this presentation, but if you just click through to one more. Okay, sorry, one more. Oh, one last thing, we did do kind of a pretty excessive market scan and looked at over 450 digital platforms that exist in the market today that provide some or all of these various capabilities. And one of the big takeaways is that there's not one existing program or platform that addresses everything that we want to do. So we're trying to be thoughtful about that as we think about our procurement strategy and how we kind of piece all of these important things together into one virtual services platform for young people. I think the next page probably just has contact information. So I'll stop.
Yes, thank you so much, Autumn. That's very helpful. And I have a couple of questions that I want to ask, but we're going to hold questions until our discussion. And at this point, I'm going to hand over to Alicia Pimentel from Anthem, who's going to talk a little bit about school-based health. Alicia, are you on with us?
I'm 2 years in and I'm still learning how to unmute myself on Zoom. So
no worries. Thank you, Alicia.
No problem. Thank you so much for having me. And I am very grateful to be going after, Angela and Autumn. I think that their presentations definitely are going to assist me in talking a little bit today about our Student Behavioral Health Incentive Program, which is being launched by DHCS across the state of California. So we are not the only Medi-Cal managed care plan that is implementing this program. If you want to go ahead and go to the next slide, that would be great. And I kind of just wanted to put up here what the expectations are around the program for the requirements as far as the needs assessment that will be taking place, the project plan that will be submitted to the state by the end of this year for those that are going on the regular timeline. And I'll talk a little bit more in detail about, what those steps look like. And then also, where Anthem is and where our counties are as far as moving forward through this project. So again, I know that this was already mentioned on the call today, but, with everything going on in Texas and, kids coming back from being gone from COVID, it's I think the administration and the Department of Healthcare Services has done a really good job of really wanting to make sure that our students are receiving the services they need where they feel the safest and most comfortable, and that's at school, right? So I appreciate you all allowing me to be here today. Anthem has 29 counties that we serve for Medi-Cal managed care in the state of California. And while this program is not solely designed to only serve those kids that have Medi-Cal as part of or as their health insurance, it is designed to increase those students in our counties who have the ability to sign up for Medi-Cal managed care and make sure that they're receiving services that they need before they, move from the mild to moderate stage to the moderate to severe. So the program is really designed to work with the managed care plans, with the county behavioral health departments and the county office of education to make sure that we are working very closely together to improve access to services for kids through TK through 12th grade. So I know we had kind of talked about previously about telehealth and the different options that are available to students right now for services around behavioral health. And I wanted to just kind of go over a little bit more in detail what Anthem's doing to work with not only our other managed care plans, but our Office of Education and our county behavioral health departments to meet the goals and needs of the goals of the department, and then also the needs of our students across the state of California. So I am having trouble seeing. Oh, there we go. Perfect. If you can just leave that up, Libby, I'd appreciate it. Thank you. So really the program runs through, originally it was through the end of 2024, but that has now been extended. I'm not sure how many are aware that some of the managed care plans that are in the state of California are going through a procurement. So we will be moving to different Medi-Cal managed care plans potentially for some of our counties. So we are not only working with the managed care plans that we are currently serving each county in. So Anthem, again, has 29 counties, 28 of those counties outside of LA, we serve as a subcontractor. So 28 of those counties, we are working alongside California Health and Wellness, HealthNet, the local initiatives in the Bay Area, Sacramento County, and then in San Benito County, we are the only Medi-Cal managed care plan in that county that is going to be implementing this program. So we have started in the beginning of, I would say, January and late December, working alongside our county behavioral health departments. The managed care plans already work very closely with our county behavioral health departments to make sure that we are coordinating care for kids in our counties for mild to moderate and SMI specialty mental health services. Many times, depending on the county, especially in our more rural counties, our specialty mental health services that come from the county do provide a lot of the services, whether that be because of lack of provider networks or because that's where our families feel comfortable going for services, even if that student may not actually need specialty mental health services. So I think the goal of this program is to really make sure that we're meeting students where they are and making sure that before they end up needing additional care, if they are, identified in their school district as needing mild to moderate services, that they get those services on campus prior to maybe needing a more intense level of service from county mental health. And then just making sure that, the schools, the mental health plan, and the managed care plan are working very closely together to coordinate services, not only for behavioral health, but making sure that, maybe a kid comes in for a stomach ache, they're identified, they are screened, they need mental health services, to make sure that all of those partners are working more closely together and that we're not operating, and I know this word is used so often, but not operating in silos and making sure that, we're accessing services for all of the kiddos in our communities. So we have started to meet with all of our counties. We meet with the other managed care plans. So in Sacramento, we have 5 managed care plans. In some of our other counties, there are only 2 managed care plans. We are required to work with those counties to submit a assessment and project plan. The assessment will consist of a mapping tool. We will do data analysis, make sure that we're working with local community providers to ensure that the data collection that we're, the data that we're pulling is then provided to the state to identify where the gaps are within each of those counties. So I think that you all can see what Libby has pulled up, and this is kind of just an overview. Some of our counties have chosen to work with a third-party administrator. So we have contracted with a consultant to work with our counties. Let's, as an example, in a 2-plan county, I'm just going to give an example of Sutter County, where we have California Health and Wellness and Anthem Blue Cross. We have contracted with one specific consultant, and we're working on making sure that these different benchmarks are met. We have submitted our partnership forms for all of our counties. Those partnership forms include LEAs that will be participating in the assessment. So the LEAs that are on the partnership form have been submitted and approved by the state and are currently going through the assessment process. Those LEAs are working with not only our TPA, but our county behavioral health and the managed care plans. So we're pulling things like our membership data, our claims data around services that we're providing. We're pulling data around our provider networks for both of the managed care plans. There are other pieces of data that we're pulling from the school districts. So things like healthy kids surveys. A lot of our counties are currently receiving MHSSA dollars. The funding that is being distributed and the dollars will flow from the state to the managed care plans, and then from the managed care plans down to the Office of Education or county behavioral health departments, depending on what is negotiated and how they're going to work that out between the NCP. Oh, I will go a little bit quicker. I'm sorry about that, Libby. So basically, we're in the needs assessment piece. We plan to submit the needs assessment at the end of the year. So both the needs assessment and the project plan are due by the end of 2022. There are 2 counties that we currently have that are going to be going on the early timeline, and that's Santa Clara County and Sacramento County, and they will be moving forward a little bit more quickly, and they will implement their interventions prior to the 1/1/2023 implementation date that the other counties are going to be moving forward with. And if you want to go to the next slide, Libby. So there will be 1 project plan and 1 assessment. The assessment will drive the project plan in identifying which interventions will be implemented. There's 14 interventions that can be selected. One of those interventions being a telehealth service. As mentioned previously, I think Angela was the one that mentioned that many of our counties, although they would like to have the option to have telehealth as one of the interventions that can be implemented, they don't want it to be their only option. They want to be able to select from the 14 and make sure that they're able to, customize what makes sense for their districts. And that's basically what we are working with each of the counties on, to make sure that the assessment and project plan identify as they are submitted to the state. So once the assessment and project plan are submitted at the end of the year and approved by DHCS, the interventions that are selected will be implemented at the beginning of 2023. And here are the available interventions. Not all of our counties are going to be selecting from this list, although I think the state did a really good job of identifying a very wide range of services. There are some additional counties that may want to add on, maybe a room for telehealth services because they don't have one, or maybe, a different intervention that they've already been working on within their county that they'd like to expand on to other districts. So, we've been working very closely with DHCS to make sure that those are approved prior to us submitting the assessment and project plan. And I'm sorry, I tried to fit that all into 5 minutes, Libby, but
no worries. This is super helpful, and I love this slide, Alicia, that really just gives us that snapshot of how you and other plans are meeting students where they are and really providing some on-site support to them. That's so important right now. And I welcome questions for Alicia, comments in the chat. I'm going to take a moment now. Thank you, Alicia, and introduce Petra Steinbuchel, who is a wonderful partner for us, to us, and she is also a psychiatrist at UCSF Benioff Children's Hospital, Oakland. She's the director of the Child and Adolescent Psychiatry Portal Program that she'll talk a little bit about today. And Petra, with this, I will hand off to you.
Thanks so much, Libby. I'm really excited to be with you all and to talk a little bit about our program, which is intended to expand access to pediatric mental health care. Next slide. So these statistics may be very familiar to everyone here, but on the left-hand corner of this slide deck, you can see that this is from a Kaiser Family Foundation survey that was reported in 2021, and just the extraordinary difficulty that people had in finding a provider and not having the time to get off of work, not being able to afford it, and then reasons of stigma and other difficulties accessing care. And the map on the right is the workforce distribution map across the United States for child and adolescent psychiatrists. And then in particular for California, you can see that in general, there is a severe shortage throughout most of California with only a high shortage in some of the more urban areas. And with many of the Northern California counties really not having any child and adolescent psychiatrists. So the estimated need for is over 40,000. And in reality, there are about 8,000. And these ratios are similar for child therapists and developmental and behavioral pediatricians. Next slide, please. So our program started about 2.5 years ago, and this is not a new type of model. This is a pediatric mental health care access program that is modeled after several other programs that first got started in 2004 and now exist in over 46 US states and territories, and are state funded in over 20 states. And the main components are real-time consultation with primary care providers. And also we are piloting some work with schools and school-based health centers and with therapists. We also offer a direct connect psychologist consultation in certain specialty areas, including eating disorders and early childhood, and continuing medical education. That's as much about imparting the didactic information as it is about really developing relationship and trust and community building and networking. We also offer care coordination to families who have added difficulty in accessing care, whether that's because of motivational barriers or language or other factors that really make it difficult for them to access care. And then we have a number of resources on our website. And the start of this seemed to come at a really good time because it started in September of 2019. And being able to provide this support virtually has been incredibly welcomed by primary care providers who have been facing an extraordinary increase in the number of mental health concerns in youth. Next slide. Right here is just a little bit of a map of practices that we've enrolled. We've enrolled over 200 practices across 28 Northern California counties. And that means about actually over 1,000 providers. And we've done over 1,700 consultations so far. Next slide. These two columns are from excerpts. The one on the left is from a book on integrated primary care, where really it highlights a lot of the common thoughts. This is from focus groups done with PCPs that beforehand, whether, in whatever type of integrated care model, they feel like this is going to slow me down. I don't have time to address one more problem. I already do a good job of treating mental illness, and this is going to drag on me like an anchor. And then afterwards, really appreciating the benefits and what they've learned, and that it takes a load off my plate. It speeds me up. I always want to practice like this. I'm giving better care to my patients, and it gives me time to finish my notes. And I think indirectly, we have been hearing from providers that it really helps with their feelings of complete overwhelm and to some degree burnout at trying to manage things that they really don't feel equipped to manage. And then on the right here, this is some data from the MCPAP program in Massachusetts, which was the first statewide program where most families really expressed a lot of satisfaction with their primary care providers' handling of their child's mental health. And it really seemed to serve to strengthen the PCP's role in their mental health care. Next slide. So this is a continuum of technology-enabled behavioral health integration. And so in the kind of left-hand three, you have non-provider, non-person dependent, really patient-facing technology that can include apps and web-based services and text messaging and digital therapeutics. And there are a number of apps already out there, as Autumn had mentioned earlier. And then the next four are really aimed at building PCP capacity to treat mild to moderate behavioral health conditions. And you can have this embedded within your EHR. CAP is offering these three in the colored boxes. So specifically e-consultation, where you request it and then asynchronously you get a note back. And then there's Project Echo, which is a peer teleconsultation model that helps to improve knowledge and comfort through developing knowledge within people who are providing the care. And then you have remote telehub consultation, which is warm line phone consultation. Next slide. So this is a brief overview of how our teleconsultations work. A provider can either call and provide some brief demographic information or enter a request online. And then the psychiatrist calls back and there's a discussion for anywhere between 5 and 20, sometimes longer minutes, depending on the complexity. But we really try to look at how much time the PCP actually has and how complex the questions are and what they seem to need. And then after that, we send a consultation letter, either by secure fax or encrypted email back that summarizes the recommendations. Next slide. Then for e-consults, similarly, you can enter the request online. You can do this asynchronously, and it's important to include a consultation question. And then the psychiatrist reviews the notes that have been sent and writes the e-consult note. And then there's the opening for consultation back or exchange of questions or the opportunity to consult by phone if the complexity is higher. Next slide. So this is an example of an e-consult that's come through. And so on the left-hand column was information that was provided by the primary care provider, which was fairly inclusive in kind of a short summary here. And so knowing that this child has all of these diagnoses and services in place already, and then the newer onset symptoms of anxiety, and then what meds had been tried, and what the outcome was, and what the specific consultation question is. And then on the right-hand side, these were the specific recommendations that included a screening questionnaire and discussion of potential medications and also kind of the practical application of that. And then kind of a stepwise approach, but also being careful not to get overly complicated or too far down the road in that in case there's an adverse reaction. And there are links and screening tools and handouts included. Next slide. And then in contrast, this is a teleconsultation that ended up, on the surface, it looked like it was a medication question about depression in a teen who had tried and failed 2 SSRIs. And so the question was, should we, continue to increase this? And then in the dialogue, come to find out the patient had actually previously been diagnosed with ADHD, had never gotten any support for that. And so the depressive symptoms seemed to be a result of undertreated ADHD that was really doing a lot worse in the context of the pandemic. And so this ended up resulting in kind of reevaluating the diagnosis and the overall treatment plan. Next slide. This is a very small snapshot of our partners across Northern California, and Anthem and Blue Path have been wonderful partners in this process. So thank you. I'm going to pause there.
Thank you so much, Dr. Steinbuchel. We really appreciate your time, as always, really supporting this great work. And I think I just love the fact that you landed on some case examples. We hear over and over again in our monthly calls that payers, providers, consumers, patients really want to see how eConsult works, the kinds of questions and answers that come through, and how providers can actually engage, and that it is doable, that this is a means of communicating between primary care providers and specialists in a simple way. So thanks for sharing those examples. And I welcome some questions to come through the chat. I know we have about 10 minutes left. I'm going to throw out a pretty broad question for each of you that you can each respond to. And I will start, I think I'll start perhaps with Angela, but this is a question for all of you. What is your call to action for those people who are on our call today? We have payers, we have providers from FQHCs and public hospitals and other health systems, academic medical centers on our call today. So we have payers, providers, policymakers. What is the call to action to really help to address the crisis that we are facing? What can you do, what can our group do to help you with your mission and in addressing behavioral and mental health needs? And I'll ask you, Angela, first. What is the call to action for us?
Thanks so much for that question. The call to action is really to think expansively about what we consider mental health care. We heard over and over again from young people of color that the existing system of care is not set up to meet their needs. It is, it's largely white providers from upper and middle income communities serving largely, Black and brown immigrant communities without a lot of cultural humility and cultural competency. And I think what that means is that we need to immediately open up opportunities for mental health care through peer support in particular, so that folks are, we heal in community. That's something I learned as a social worker, and I saw it very much coming from youth. So helping them to build community with each other, build community with, their elders, and consider that mental health care and pay for it as such. So resource community-based organizations who are providing this kind of non-traditional, non-clinical support. We need to resource them to do that kind of mental health care prevention and early intervention work that they are doing. So that is my call to action. Thank you.
Thanks, Angela. Okay, Alicia, I'm gonna put you on the spot now. What is the call to action for us in terms of school-based mental health?
Can you repeat the question? I'm so sorry.
Alicia, what can we do as a work group of providers, payers, policymakers? What can we do to raise school-based health in terms of priority? What can we do?
What can you all do as in your organization, Libby, right?
Yeah, or us as members or participants of the work group.
To raise awareness for school-based health. I mean, I think that the state has done a really good job of making sure, there are a ton of programs going on right now and being implemented. I think that as a group, making sure that you're participating, if you are, if any of the school districts in your school districts that you are currently, and let's say you're in, I don't know, Butte County, right? Making sure that if you're a local provider, that you're participating in the mapping tool, understanding what the gaps are and the needs are for those schools, making sure that if you're a provider within those districts, and Libby, cut me off if I'm not answering the question in the way that you were wanting to have.
Right.
But if you're a local community-based provider and, you're willing to partner with the school districts or with the, county mental health plan or with, the managed care plan, identifying, I think one of the things and one of the pieces of the student behavioral health incentive program is making sure that it's a sustainable program, right? So those contracts, let's say that one of the initiatives that, or the interventions that the school decides to choose is, hiring a person, let's say a clinician, to provide services on site, because we all know that when you see someone every day at school, you're going to feel more safe in talking to them, whether that be a clinician that's also a yard duty person. I think that, just as providers within the community, making sure that you are involved in all of these different programs that were brought up today, making sure that you can contract with your local managed care plan for services to provide behavioral health services, making sure that, we share resources, right? There's a lot of different collaborative meetings that I think, when we were talking to a lot of the schools as we go out and do these assessments, we're like, well, we offer kiosks, we offer things with county mental health. We have relationships with different local community-based organizations to make sure that there's telehealth options on site for services. Making sure that, we all know what the other partner offers, because there were things that I've learned that I didn't know. I think, acronyms are a big thing. I think for the school districts and for the managed care plans and county mental health and the state, there are a lot of things that are going on that I think we all don't realize are going on, and making sure that I think that's my favorite part about the Student Behavioral Health Incentive Program, is that they're doing these assessments to make sure that we are identifying where the gaps are, and we're working together to make sure that, we fill those gaps. But I think that there, not that there are not going to be huge gaps, but I think, that there are a lot of services that are already happening that we don't all realize are happening, and making sure that we're listening to kids. I think that, you know, in the beginning, Angela had talked about, you know, kids maybe don't want, you know, traditional therapy services. Maybe they want yoga therapy. Maybe they want to have, you know, goat therapy. You know, where they have yoga with, you know, animals or things like that. You know, we've worked with Santa Clara County to make sure that we're funding projects around their, you know, wellness centers. So I think listening to children, understanding what makes sense for them, what they feel comfortable with, and then making sure that we're able to build out those programs based on services that they're actually going to use, right? Not what we think they want, but what they really do want.
Yes, that's an excellent point there. Thank you so much, Alicia. And Dr. Steinbuchel, I know this is a hard one for you, and as a provider, what can we be thoughtful of during this time of crisis? What's our call to action as you know, supporters of patients, providers, and you know, addressing the crisis that our children are facing?
Thank you. I mean, the need has been there for so long, and just as evidenced by our most recent tragic school shooting this week, it just really speaks to the need for more education and really elevation of everyone's collective mental health literacy across the board. And mental health has historically been something that is kind of kept more quiet or in the background, not talked about, and carved out, and also with separate record keeping systems, separate billing. And I really so much appreciate the movement towards kind of getting away from that, and towards depathologizing also, for example, not requiring a diagnosis through the no wrong door approach. And trauma-informed care principles invite us to really take a strengths-based approach and ensure that we're looking at more comprehensive care. With that, my hope is that there's more and more behavioral and physical healthcare integration, because it is, you know, a whole person and a whole family whose needs we're trying to address. And so with that, thinking about what's called stepped care, meaning that you have the right provider at the right time, or the right service at the right time. That may include things like yoga, or may include, you know, community interventions, and then have that for the right length of time. And so I really applaud the possibilities in front of us right now. And of course, I can't help but put in a plug for, you know, thinking through supporting more behavioral health integration that includes CAP services, e-consultation, and online consultation that has been shown to expand access to care.
Thank you so much, Dr. Steinbuchel. And we'll make sure that, please do take a look at the chat. We'll make sure that the links to learn more about CAP and get involved if applicable. And I'm going to ask Autumn for you to wrap it up, since we're short on time here, but how can we provide input to DHCS and to see the California Youth Behavioral Health Initiative? How can we help?
Sure, great, thank you. I think you let me off the hook by having me go last, I'll say, because I was just going to say ditto to everything that everybody else said. I mean, I think one of the things that we've heard today from all of the panelists is that really meeting the behavioral health needs of young people in California is all of our responsibility, and we all need to take action in order to really heed the call that young people are you know, screaming quietly that they need help. And so you know, I do invite you all to stay involved in the development of the work under the Children and Youth Behavioral Health Initiative. We have frequent opportunities for getting involved in terms of stakeholder engagement processes. We have monthly webinars where we provide information about the various work streams that we're focused on under the initiative. There's also just lots of different kind of events and activities. So invite you to be partners in that work, to engage, to partner, even if it's not with us. You know, I think what Alicia and Angela were talking about, partner with those in your community to try to meet the needs of young people, is really, I think, what we'd ask. We also, as part of the deck, included our contact information. So invite you to share your thoughts with us and help us to co-create and co-design this behavioral health virtual services platform and the e-consult feature, and really thoughtful, you know, want to have thoughtful input from all of you about how to make this a product that will work not only for you as providers, but also for our young people. So really would love to hear and get input on how we move forward.
Thank you so much, Autumn, and thank you to our presenters today. We went right up to the very last minute. Just wanted you all to know that this recording and slides will be available at econsultworkgroup.com, and we will make sure to get this information to you since there's such a rich amount of data in our presentation today. And please do save the date for our annual meeting in November. Thank you all for your time today.
Thank you, Libby. Thank you, everyone. Have a nice day. Have a nice Memorial Day.
Thank you.